Airway Management.
Megan and Ariel here from the OakLeaf Respiratory Therapy team. We just wanted to cover a few of our airway skills so that you guys have a video that you can reference in the future. So we're going to go over a few things today with you.
Hope you enjoy.
So one thing that we use a lot here is the oral airway. One reason we use this is because when people are coming out of anesthesia, their gag reflex is not going to come back right away. So this is a safe adjunct to use to make sure that we're still protecting their airway while they're waking up. The way that you put this in is first you're going to measure for size. There's several different sizes that you can use. The way you do that is you're going to go from the corner of the mouth until the mandible. Because this part's going to sit at the back of the airway there. The way you're going to put it in is you're going to turn it sideways, watching out for the teeth. A lot of times you may need to use a tongue depressor. And then you are going to flip it downwards and follow the way of that airway. This little part is supposed to sit right in front of the teeth so that it is not going down into their airway. And then a lot of times you will see this in conjunction with a simple mask that will sit right over top, and then you can tell that you have good ventilation by seeing that fog return. So when your patients are coming out of the OR, a lot of times they will be coming out with a simple mask. The simple mask is always going to be on at least 6 liters or more. That is so that your patient is not retaining CO2. If you don't have that higher flow, then it's going to be not flushing out of the mask. So your patient has a simple mask on, they have their oral airway in place. I'm not going to be this mean to my patient. You do want to make sure that the straps are kind of pulled tight because again, the initial step that we're looking for when a patient's coming out is that we have that exchange, that fog we're seeing. If for some reason you don't see that fog, then we're going to make some adjustments. So one tool that we use quite often as patients are coming out of anesthesia is going to be either a chin lift or a jaw thrust. That's simply going to be finding the back of that patient's mandible for the jaw thrust, and you would lift up and position until you see a nice fog and exchange of ventilation there. Otherwise, sometimes patients don't have a great place to grip right there, and you might need to do something as simple as a chin lift. The mannequin doesn't have that much mobility, and some patients don't either, but you just have to find what's right for that patient until you can see that exchange.
Hi guys, we're gonna jump right into the next airway adjunct. We're gonna go ahead and these are our nasal pharyngeal airways, or known as the NPAs or nasal trumpets. They come in various sizes from size 5 all the way up. I think we carry 8.5 is our largest, which we have right here as well. For using on our mannequin, he prefers an 8.5. The way you're gonna go ahead and measure on a person is this from the nair opening to the earlobe, and that is going to be your adequate size. If you're guessing size, it's always better to go up in size because the point of the nasal trumpet is to be going behind the base of the tongue. That way you can provide that perfect ventilation. So for the nasal trumpet, the one thing that it's going to be different from the oral is that you are going to need lubricant. You should always have it paired together, or it always should come paired together, or at least provided in the same bag as the nasal trumpet. Don't mind me. Okay, so you want to make sure you get all the base lubricated, so it's a smooth transition, because it doesn't seem like a very fun thing to have in somebody's nose. So what you're going to do is beveled side is going to go towards the septum, and you're just going to follow the anatomy of your patient. So you're going to go ahead and place it in. If you're guessing which side to place it into a patient, it is surprising, but, and there you go, you follow the curvature of the patient as the gel leaks into their eyeball. That doesn't happen. But like I was saying, if you're questioning the size or the side on which to go, the smaller nair is usually the more anatomically easier to go and follow. Now this nasal trumpet is more tolerated by conscious patients. They can have a gag reflex as well. So it's really based on how you would like, or when you would like to take it out, that you think that they're going to be able to protect their own airway. The same thing with the oral is we're going to apply that simple mask then over the top of it. You will have a confirmation of correct ventilating when you do see that fog return in that mask. All right, guys, now the removal of the nasal trumpet. So it relatively does come out fairly easy. You're just going to place the mask to the side here. You're going to tell your patient to kind of pretend like they're blowing their nose. And it just gives that effect of them being able to blow that kind of out. So once you tell them, excuse me, sir, can you blow your nose here? Ready? 1, 2, 3. And then it should just ease out smoothly. Again, like the oral, it catches a little bit. It does not look that painful. So it should just slide on out. You give that a toss.
Now we're going to go over the adult airway adjunct that's going to be that passive way of ventilating that both RNs and RT are able to place here. Again, in the situation that anesthesia, CRNA, or RT isn't present, and somebody is needing a more controlled airway. So there are 3 sizes that we carry in our crash cart. We have orange, green, and yellow. Just a reminder that with the I-Gel, that is just talking about the cradle that they're sitting in, not the I-Gel itself. We do have these handy dandy little size charts that are sitting inside the airway cart that will kind of help you decide which size is going to be best for your patient. Typically for an adult male, you're going to use the green size. An adult female is most likely going to fit yellow. And then for your really tall guy, not necessarily big and bulky, but your height is what we're talking about when it's talking about lung capacity, then you would need that larger size. The really awesome thing about the I-Gel is that manufacturer says that you can go one size up or one size down and you still can properly ventilate your patient. So, sorry, that is our halo. But so you will be able to ventilate the patient regardless. So if you are feeling uncertain about the size, go ahead and grab the green, and that will be a pretty safe bet in an emergent situation. All right, so for our mannequin here today, we are going to be using the green I-Gel. What you would do is you would grab this from the crash cart, you would put lubrication all over this. Sorry. And the way that you're going to insert this, you're going to just follow the curvature of the airway, making sure that you're not pushing the tongue back into the throat. You can try and insert the I-Gel up to 3 times before you need to stop and get another, a new one, or hopefully somebody would be there to be able to assist in intubation at that time. The reason for this is the I-Gel actually is able to warm to the anatomy, so it actually makes a really nice seal once it is inserted, which makes for better ventilation for the patient. But if you are inserting it and taking it out, then it can expand and it's not going to sit correctly. One other nice thing about the I-Gel is you are able to put an OG in, and on that little cheat sheet there is different sizing for your French size of your OG. So you're going to go ahead and just insert that. There is going to be a little bit of pushback because again you're going through a little bit of anatomy there. And then this would actually go in easier on a real person and a little bit further. It has a built-in bite block, which is really nice. And then again, you would attach your Ambu bag and look for that chest rise, auscultation as well. Then once you are done inserting that, again, you would tape it, making sure you're not letting go of that tube before it is secured. And then hopefully we would be getting this patient off to a higher level of care. Alright, so we just wanted to go over the different Ambu bags that we have available here. One of the types of Ambu bags we have is the self-inflating. These are really nice because if you don't have an oxygen source, you still are able to initiate that breath for the patient until you're able to get it hooked up to oxygen. Again, just making sure that you're having that really good seal and seeing that chest rise. We also have our anesthesia bags that are used in the back, and then we'll a lot of times come out here after OR, and we also have them stocked in the PACUs. These are going to have to be hooked up to oxygen flow in order to be able to ventilate the patient. But the nice thing about these is if your patient is breathing spontaneously but still asleep, you can see them take their breaths and you will not have to physically bag. You can still give them breath, but you don't have to if they are able to initiate that breath themselves. Another nice thing about the anesthesia Ambu bags is that there is the ability to initiate PEEP or CPAP. And how we do that is you want to make sure that you see that little red portion. If you can see the red portion, you are giving them a little extra pressure, which will help with oxygenation. If it is open, then you are not giving them that extra pressure. Sometimes we don't know how much we're actually giving into those lungs for a breath. So my hand alone can give up to 5 liters of oxygen just from one little squeeze on the Ambu bag. So you don't want to cause barotrauma by over ventilating someone. When you're giving a breath like this, that actually can cause barotrauma. So be gentle with our breaths.
All right, as we wrap up our segment here on airway management, we're going to discuss the 3 oxygen delivery devices that we use most commonly here at OakLeaf Surgical. Displayed on the screen is a simple mask. The simple mask is going to be utilized on our patients mainly in their OR portion, more commonly found coming back to PACU with a simple mask on. The thing you want to remember about a simple mask is that they need a minimum of 6 liters. That allows the patient to not be at risk for retaining the CO2. The mask is able to go up to 15 liters, but you need a minimum of 6 liters. Once your patient starts to wake up, you will start weaning them off of the oxygen, and you will need to take off the simple mask and place them on either a oxy mask or a nasal cannula. Now displayed on the screen is a oxy mask, a personal respiratory favorite. That is because of the versatility in which it can deliver oxygen. It can deliver oxygen from 1 liter all the way up to 15 liters or flush on your flow meter. There is no minimum nor a maximum of amount of flow you can provide using an oxy mask. It is best used by our patients that are just waking up because we are uncertain as to how much oxygen they are going to be needing. And lastly, displayed here is the common nasal cannula, favored by many people because of its simplicity. However, it is very commonly misused as people try to turn them up past 6 liters. It does have a maximum of 6 liters, and once it reaches past that, it is inefficient and will not provide the patient with more than 6 liters of oxygen. So it can go anywhere from 0.1 liter down or up to 6 liters. Once you get past that, and if your patient is requiring more than 6 liters, then you shall switch them to an oxy mask to be able to deliver them the amount of oxygen they need safely. Oh, I'm Airway. Airway.
Management skills.